products and tobacco from February 2015 until his appointment as the commissioner, which he held through mid-January 2017. Prior to joining the FDA, Dr. Califf was a professor of medicine and vice chancellor for clinical and translational research at Duke. And we know Dr. Califf for his many landmark clinical trials, primarily in cardiovascular disease. And he founded the Duke Clinical Research Institute, probably to support a lot of his cardiovascular clinical trials. Dr. Califf has more than 1,200 publications in his peer-reviewed literature. And how's that for scientific stature, folks? Dr. Califf became a member of the National Academy of Medicine in 2016 and has served on numerous IOM, FDA advisory, and NIH committees. And Dr. Califf will be talking about a subject near and dear to me, using the vast amount of existing data from administrative claims, registries, electronic health records to develop an evidence base for assuring the safety of marketed products. So these data can be used for healthcare quality and effectiveness. So thanks very much. Let's go.
Thanks. It's great to be next door at another great institution with its origins basically in ACC basketball, as I understand the history. NC State, Duke, and UNC all coming together to form an organization that has grown, and I learned from Wayne, is now up to almost $1 billion in revenue per year. Quite an accomplishment. Wayne and I, by the way, go back to the same hometown of Columbia, South Carolina. Both high school basketball players, and having a lot of fun. Looking forward to this upcoming year, which I'm sure will be great fun in the Triangle. So I'm going to talk to you about a serious topic today, and I think it's more serious than it's ever been. Not just how to generate evidence, but beginning to think about what to do with evidence once it is generated, and about evidence for health, not just evidence for health care. And some of the experiences I had in Washington had an influence on my thinking on this. And as noted in the slide here, I chose to go back to a job half-time in North Carolina, which I think is emblematic of a problem that's tearing our country apart right now, and half-time in Silicon Valley, which is maybe the origin of tearing our country apart in some ways. But also, I think, holds the key to the solutions. And I'm going to talk a bit about that. For those of you who don't know, Verily Life Sciences is part of the Alphabet family of companies that were formed through Google, and it's sort of the main medical products outlet for all of the creativity that happens in that vast universe, which I'm still trying to understand 4 or 5 months into it. So right now, I get on a plane every 2 weeks and fly to California and live there for 2 weeks. Life at Google is not bad. I have a nice apartment in the Presidio, so don't feel sorry for me. We are spared from the fires there and have a great view of the Golden Gate Bridge and the Pacific Ocean. So life is good there, but I welcome the getting back on the plane for it to spend 2 weeks here in Carolina, where I think there's a lot of good work to do with people who are experiencing a lot of interesting difficulties. So a lot of what I'm going to say could be a little bit depressing unless we work our way out of it, but I do want you to know I'm an optimist, generally speaking, and it has been an amazing time for me. My career in medicine really started with an idea that I would become a pediatrician, but I got corrupted by working with a database in the 1970s before most people were working with computers in medicine. And I became convinced that the main way out of the medical care wilderness was through high quality evidence. And indeed, as I became a coronary care unit director, that was a year when we figured out that blood clots cause heart attacks. Quite remarkable to medical students today if you say in 1978 we were taught that blood clots did not cause heart attacks, but it's nothing like a picture of a blood clot sitting in a coronary artery to clue you in as to what's going on. So there was a case of technology making a difference. the race was on, and because we had access to computers that other people didn't have at the time, we became a global coordinating center for development of therapeutics in that field. But alongside that were a number of other things that you all are experts in understanding that have led to a dramatic reduction in risk of death until very recently in economically developed countries. And now I think we're in for a real revolution in information, a time that many of us dreamed of at the time. When this started for me, when Frank Harrell was first working on the C index, we would press a button, I remember, and go to the local pizza place for beer, and then get a good night's sleep and come back the next morning, and the program would have run to give us an answer. We're in a very different era now, and the combination of cloud computing and massive arrays of processors have changed the computing world in a way that I think most people haven't really come to understand yet. I'm not pretending I understand it, but I'm seeing the power of it in my everyday work. And so I really do believe it's the case now that this revolution has no technological limit. The limit is really the culture that we live in and the way that we create rules and deal with the information that we have. And so this is a list of approaches or things that need to be done that came from the sort of joint work at HHS in the Obama administration, where I have to say I had fun every day. Not sure I'd be having fun if I were there today. The environment is a little different. But the idea here is that we've got to change the culture to catch up with where the technology and science are, or we may not only not take advantage of the technology, we may actually lose ground compared to where we've been for reasons that I'll try to explain, and we'll see if I'm right or not. So my asymptotic goal in this phase of my career is to work with other people who can make this happen. But I really do believe, and I'm sure Sue would agree with this as an aspiration, that I really don't think there's a technical limit now to people having clear, understandable information about the benefits and risks of medical products, but also of other medical interventions and major decisions that really have a much bigger impact on health than what happens in the delivery of healthcare. But you probably agree with me that we're a long ways from this right now. And as I said, I don't see a technological limitation. Just one little anecdote from yesterday. We were on a call talking about Google search, which I'll talk a little bit more about at the end of the session. And the point was made that the conversion of medical language into 110 languages from English is now something that's mostly automated. So things that used to take armies of people to translate, now I won't say it's as simple as pushing a button and you can take it all for granted, but it's happening very rapidly. So if you imagine a global tool like Google search that you've got to develop in 110 languages, not too long ago you had to have 110 different groups of people who could do the translation. Now it's mostly done through machine learned automated systems. And I'm sure there will be errors with that. You might say, as we learned with mosquitoes recently, that is telling boy from girl mosquitoes, it turns out humans make a mistake because they're looking through microscopes at little mosquitoes about 1 out of every 100 or so times, but machines make a mistake 1 out of 2 million. So quite a difference there. And I don't need to tell RTI that this is not about healthcare delivery. You all are in the place that does a lot of the work to demonstrate and deal with the issue that most of health is determined by things that happen beyond traditional medical products and the traditional healthcare system. We have an urgent need in the United States today, and I think this is much more dire than most people currently understand. And I may be overplaying this for effect, but I don't think I am. And even this morning, now that I'm back on the tweetosphere, they told me I couldn't tweet while I was FDA commissioner. My compatriot Andy Slavitt, who was head of CMS, tweeted away. I never asked him why he got to do it and I didn't, and I finally did once we were on the outside, and he said they told me I couldn't tweet either. I just did it. So I made a mistake in following orders. But this morning we were musing about this latest picture from CDC showing that the middle of America, and North Carolina, fortunately for once, was not in the bad group. But if you go just west of North Carolina all the way to Ohio and Michigan, the rates of tobacco use are now exceeding economically underdeveloped countries and headed the wrong direction. So, all right, but that's only the beginning of the map. So first of all, the good news, something you all know, people are living longer than ever before. It's been the case since 1918 until very recently. And it has been this combination, particularly early on, of broad public health things, and then more recently, healthcare delivery, particularly related to cardiovascular disease and babies. I'm totally free to talk politics now since I was a presidential nominee. I hope you will all pay a lot of attention to the support programs that have just been withdrawn from the states to prevent pregnancies. The problems I'm going to show you are going to multiply if something doesn't happen to turn that around or deal with it in some way. And you're also well aware that the benefits that have accrued are not uniformly accrued. This is from Chris Murray's group in the key paper about the 8 Americas in 2006. And the simplest way to think about it, the lower left-hand corner is African American men. The upper right-hand corner is Asian women. There's over a 2-decade difference in life expectancy, and this plays out in multiple dimensions across America. But now I can say this is not me preaching about people who are suffering from disparities. I can talk about myself now. This is a slide on middle-aged white men. America is the red line. And you see all the other major economically developed countries, middle-aged white men. We are distinctly different. We're headed the wrong direction. This is not like it was before, that we're just experiencing less of a decline in death rates. We're actually seeing an acceleration of mortality now. And these are the slides that I like the most. Recently, Murray's group from Seattle put out a host of maps about every disease you can think of, but they all look the same. And when I show this to people and say, what is this? Most people say it's the election map. And in fact, if you this is county by county mortality, where blue is better and red is worse. You'll notice we're in or close to real badness here. Right here surrounding the research triangle. And in fact, if you did a map and you just singled out university communities or urban areas, they would look blue, and everything around it looks red. But I think even more importantly, this is the trajectory of life expectancy. So this is not a static issue. There's significant trending going on in the wrong direction in many counties in the United States. So we have a big problem. It's a close alliance of what looks like, this is all correlation, but you can put voting preference, income, education, and race, and it accounts for most of this in correlations. And in fact, Murray's group, did the work. The good news for people like me who grew up as cardiologists is there actually is a role for healthcare delivery in this. It was a statistically significant factor. But just like the pie chart that I showed at the beginning, and like all public health schools have taught, it's income, education, race, and location that are the dominant factors. And just more evidence for it from other sources. If we look at cardiovascular risk as a function of income in tertiles, whether we look at the left-hand side at NHANES risk score, or you look in the middle, I believe those are, that's blood pressure, systolic blood pressure. And you look at the right-hand side at current smokers, This is basically a division of the country based on income and other social factors. And of course, this is happening at a time when we can measure this with increasing precision to the level of the household. And I'm now living half of my time in a place where we pretty much have measurements on everybody everywhere, including physical location and environment. But there's something we're not doing right with all this information, or somehow it's not being interpreted well. And I think the key issue to me is that even the poorest people in our country and most of the world have access to more information than any of us had 5 years ago. It's sitting right on the cell phone. The question is, how do they find truth and expertise in the midst of all the other stuff? And all the people who would have them believe that bad things happen to people simply as a result of God's will, as opposed to a set of factors that are modifiable, that can be dealt with proactively through policies, social interactions, and individual behaviors. So I'll start with the 1% or less of our life that's spent in a hospital or a clinic. And at least there, we do have a large amount of money being spent collecting information now. And I think there is hope. And in fact, we have a scientific method. Recently, with our new president at Duke, whose history, interestingly, his academic history is studying public discourse about controversial issues. And I was asked to opine about my experience at FDA. And, what I'd say is that although I was attacked every single day at FDA, people generally come to the FDA expecting that they will have to use data to defend their position. It is a general expectation. And sure, it gets heated, but there is a well-honed system held up through decades of court decisions and guidances and federal rules that pretty much get people in the lane of arguing about the data. Whereas in the more general policy arenas, it seems like we're losing any view that actual data should underpin the views that we have about what the right policies are. So we had quite a fun discussion about how to interpret what I was saying. I came out of it thinking I'm right. That and the question is now: is it possible to move other elements related to health into a more evidentiary system as opposed to an opinion-based system? Well, but getting back to medicine per se, we would probably all agree the right way to develop medical products is to have a theory that develops through science and then test that theory in preclinical models and early clinical trials, and finally in larger clinical trials of one type or another. And at the center of it is a body of knowledge which accrues over time as the product is used. But the problem is the system that we currently have to do this is absolutely hated by people who have to do it. It's living in the 1950s. It's based on developing a parallel universe like a lab experiment with living people, and having nurses that fly around on airplanes and manually check data to make sure that it's right. And a fortune is spent on this in such a way that people who really are good at practicing medicine don't really like to participate in it. There are a lot of other reasons why clinical trials don't get done in practice, but fundamentally, we have a system that's not delivering the goods. And the result is that even in organized medicine, the vast majority of major decisions that are made are not based on high quality evidence. Companies will spend a fortune getting through the FDA, but then after that, most of the evidence that we have doesn't really answer the dominant question that patients have and healthcare providers, which is, out of all the treatments, which is best? How do we combine them? How long do we give them? And so we have this tremendous and more easily identifiable societal need now that's not being met by the current system. And to make it even worse, because of all the rules that we put into place and the way it's done, there's a hyperinflation going on in the clinical trials world right now. that's making it likely that we'll answer even a lower percentage of the critical questions with less complete information unless we change the way that we're doing it. Are you depressed enough now? Here's the good news. The organizational substrate for a better system, I believe, is developing rapidly, and I hope is near a tipping point. And it really was generated by the old HMOs, but I would just call this now the Amazon, Google, Facebook, Walmart slide. This is the way they function. Every time you touch them, all the information is recorded in digital form, and it's all looked at by somebody with a constant effort to make your experience better, and in most cases to separate you better from your wallet for particular reasons. In the healthcare system, hopefully there's a different mission, which is to enable you to improve your longevity and quality of life. And literally, in the Google world, the key to Google search is the auctioning of ads. But in addition to that, a constant refinement of the product using what's called A/B comparisons, which are nothing other than pragmatic randomized clinical trials. Every time you do a search, you're participating in multiple pragmatic randomized trials. But their endpoint is integrated ad revenue over time, not patient outcome. When you turn off your cookies, you're lost to follow-up. So they have wonderful imputation algorithms and pretty much everything that we think of in human clinical trials, but just with a different endpoint. And so, what they would say is, for a business that needs to be dominant, you can't afford to be guessing about the right thing to do. You need the evidence, so you use randomization as much as you can in the context of the real world experience. And they have a slight advantage in that 10 million people may be randomized in the first hour, but then you ask the question, how many people are going through the healthcare system now with digital data collected on every interaction? What's wrong that we're not using that information to rapidly advance knowledge? And I think part of the key is that we developed a view of human clinical trials that they needed to be segregated from the herd and run by experts, where the definition of a good research site was that it followed orders from the coordinating center. I learned about this early. It was the key to the 1,200 papers that you know about. I realized quickly that if you ran the coordinating center, you had the data, and you could write the papers. It was really a lot of fun, but I don't think it's what we need now in the current ecosystem to advance knowledge about people who have diseases. We learned that you can share coordination, but more importantly, in the United States, the consolidation in the health systems, which has both good and bad effects, I believe mostly good, but we got a lot to work through. What the HMOs realized is that if they had multiple facilities, it would make sense for those facilities to use the same data systems to centralize the aggregation of information, to analyze it, and to send it back out as decision support. And I would guess that most of you who've had to encounter a doctor or a nurse practitioner in the last year have noticed that there's a lot of information going into a computer, but almost nothing coming back. And in fact, you're probably aware of the data that right now, the average healthcare professional spends 2 hours with head and computer for every hour face-to-face with a patient. And then to make it even worse, a statistic, I don't know if this is right, I haven't seen the article yet, but apparently when clinic encounters are filmed, about 60% of the time when the doctor is asking a question of the patient, the doctor is looking at the computer screen. And there was a New York Times article this week about why I finally fired my doctor, and it was when the doctor changed from looking at the computer screen to pulling up the chair to a desk facing the other direction and looking at the computer screen towards the wall, not towards where the patient was while the history was being reviewed. But you probably, my point here is that if this can be solved for other industries, it's just a matter of time until we solve it for healthcare. We've got to have it as a goal, and then we've got a system which can fit into the growing public-private partnerships that are hungering for this activity. And here, I'm a little biased, but I want to give a lot of credit to the FDA. At the time of the Vioxx and rosiglitazone controversies about drug safety, Congress lost its composure. I guess it does this almost every day now, but it wrote a law that required the FDA to aggregate 100 million electronic records of Americans for the purpose of drug safety, and this has evolved into the Sentinel system. And the concept here is that aggregates, in the case of Sentinel, it's mostly health plans. They aggregate the data and they make it available for this public health purpose. And there are over 190 million people's records in the system, with over 40 million that are actively surveilled. So this system is working. It's used by the FDA commonly. Interestingly, the main use so far has been to debunk ridiculous academic papers that appear in newspapers and press about drug toxicities that turn out to be p-hacking for the most part. And you'll see a lot more about that in the very near future. Well, now it's official FDA policy that it wants the device industry to go wholesale into a very similar system. You'll notice the little clusters here appear on every slide, the little dots. Those are health systems. And the concept here is that you have increasingly large health systems. As a Dookie, it's a little touchy right now to talk about this happening because a huge one of the biggest in the world actually, is occurring over the next few years between Carolinas and UNC. In aggregate, it'll be something like $18 billion a year in revenue. But for business reasons, they need to collect the same data so that they can run their business. And so once we get to the point of sharing data appropriately for health purposes, this creates units that will have all the information you need to do research over time, especially if the industries and the government begin to embed into those systems some of the key information that's needed specifically for research. And so this is an FDA slide that we made when I was there, and you'd probably identify with this. Right now, we have this crazy system where clinical trials are done one at a time, except for NIH networks. They cost a fortune. The two NOAC trials that we ran at DCRI before I went to FDA each costed over $500 million a piece for one single clinical trial. Now, it turns out in those cases it's paid off nicely for the people that paid the bills, but most of us involved in those trials think you could have gotten the same answer for a tenth the cost. But the system, works that way. And for adverse events, once a product is on the market, we're very dependent on spontaneous reporting, which is proven to be highly inaccurate, very biased by things that happen in the press that call people's attention to issues. And, what clinician in his or her right mind now at 10 minutes per patient is going to stop and fill out an FDA form? People just keep on going. But what's in sight through this aggregation of health systems and sharing the data is a proactive system that would actually have numerators and denominators. This played out in a major way under my watch as the Assure and the Mortality issues came to play for women's health, where we had a lot of adverse event reports. And even in the case of Mortality, where there was a network of hospitals that had signed a contract to report adverse events, they still couldn't get them all reported in an accurate fashion. And so the idea here is to run clinical trials through the system, but also continuously follow medical products throughout the life cycle. And then for comparative effectiveness, which treatment is best, I've been privileged that, having been involved in the Patient-Centered Outcomes Research Institute before I went to FDA, when I came back, the network that we had started called PCORnet had gotten to the point it was time to spin it out, which was part of the plan. And so it's just being spun out as a not-for-profit organization to do comparative effectiveness research, and they asked me to chair the board. So I'm very biased in terms of this being part of the solution. But we know it can be part of the solution using the same methods because the NIH is also funded now a series of pragmatic trials using electronic health record data called the Collaboratory. And I'm just going to give you one example, and I'll come back to this topic in another way, and you might see the potential linkage of how a much more facile, larger system could be developed. But the issue here is that, as you know, suicide is a huge issue in the United States, an enormous issue for the military. But if you look at those mortality rates by county that I talked about, they're mostly associated with what's been called diseases of despair. This is opioid overdose, suicide, and cardiometabolic disease, which basically people not taking care of themselves. But an individual family doc doesn't have enough people actively thinking about committing suicide to know exactly what to do if a signal is there. So the idea was, let's screen people for suicidality in places that are using screening tests in primary care. And if we find somebody that's high risk, let's call them up and ask them if they'd like their doctor to be in a clinical trial. And then let's randomize the practices to one of three approaches to intervene in suicide, because like a lot of things in medicine, we have a lot of opinions about what to do to prevent suicide, but almost no real high quality evidence of the type that we'd like to have. This was, I thought, not possible when the idea was funded. I was co-PI the coordinating center at the time, and we gave it our best shot. And after 2 years of trying it out, Group Health, led by Greg Simon, figured out how to do it. And the idea is, one arm is, we think you're high risk, see your doctor. A second arm is really deep skills training in administering therapy. And the third arm is a more traditional risk assessment care management approach. And this is now enrolled 12,000 people. You can imagine this is not simple to call people in this circumstance and get the script right and get it through the IRB, which is something else I'll come back to. This is just a look at the three arms in a little more detail, but this is moving along. And what we're seeing is that we think we can get results that are equally or more reliable at a fraction of the cost of the traditional clinical trials model by using data that's already available in these health systems. Just a quick word about PCORnet. The idea here is that if we take advantage of the fact that the people that you care most about getting answers to questions, of course, are the patients and the people who care for patients who have the diseases of interest. And so by creating networks of patients who are self-motivated and sometimes highly demanding, and then linking those with health systems, we now have a network that has not only self-reported information, but also tremendous pressure on the systems to participate in the research and get the answers. Now, this is playing out now. We'll see how it all works, but I think we are learning a lot in the early phase. This is a look at the patient-powered research network. So we're learning about everything from rare genetic diseases to some of the big ones like COPD and ischemic heart disease, about how to navigate these cultures and characteristics of each of these different ecosystems. And then the data research networks, which are really data and practice research networks, are not just 13 networks. They're 13 networks that ally 34 health systems across the United States. And so we're now curating electronic health record data every quarter to a common data model on 122 million people. So it's about a third of America that's now in this system. And it's hard to think of a study that would have a sample size too large to be done by this network if we can just make it go. Still a lot of issues, mostly the culture, not of the data. The data is getting better and better. The big issue is where you need to do a prospective study is getting time for the clinicians and the patients to interact. Our test case is one that, I had promised myself in 1980 I would get this question answered before I retired. It's this really highly tough scientific question of what's the right dose of aspirin to prevent heart disease and secondary prevention. It seems like every 5 years the guidelines switch back and forth between high dose and low dose, and we're in a period of uncertainty again now. And so what could be simpler than saying, you have ischemic heart disease, we're caring for you in this health system, we don't know the right dose, it's either baby aspirin or full strength aspirin, and we'll use a random allocator to let you have one or the other, we'll measure what happens, and then we'll know the answer to the question. And so this is giving us a chance to really develop all these methods that make a lot of sense. In my Silicon Valley life, I'm just besieged by software engineers who want to know the answers to questions like, why can't I send my doctor an email and get an answer? You know, this is not rocket science, but for whatever reason, our health system is configured in a way that doesn't allow it to happen. But you can imagine the multiple ways that all of this could be automated to insert the human interaction at the right time so that we get answers and move on knowing the right thing to do, both as patients and doctors. And it's just another slide showing the same thing. And I want to stress here again that, you know, these are not called patients, they're called participants. They have an active role, had an active role in planning the design of the trial and following the trial, serving on the data monitoring committee, and will have an active role in the dissemination of results. I'm going to go on in the interest of time here. Now I just want to make in one slide the point that I'm very proud of the fact that during my tenure, we managed to get a number of things into the law that are going to push things in this direction. I'm not an experienced politician, but I learned a lot. And one of the best tricks of the FDA that I learned was, if you want something done, spend a little time with congressional staff and get them to write it into a law. Then there's a very high probability that it's going to get done. And so, you know, I had the privilege of working with some really savvy center directors at FDA who, between the cure provisions and the user fee negotiations, really had the use of real world evidence, patient-centeredness directly written into the law. So, and it's in the right way. The last thing you want is Congress writing a law that says you will do A through F. What you want is a law that says you will study the problem and come back with a guidance that will solve the problem. And that's what is written into the law. So I think it's a very good thing. And I would urge those of you who are interested in this to get involved in the discussions, because what does go into the guidances will to a large extent determine what happens. Well, we're about to enter, though, this new era. So now I'm going to switch to the left half of my life in Silicon Valley. All this that I've talked about so far deals with the 0.5 to 1% where you're in a clinic or a hospital or the traditional health system. What about the other 99%? And the idea here is that if we could map every road in the United States and keep it up to date, which is currently what's done, why can't we map the human being and keep that up to date also? It's what's been taught since 1910 between medical schools and schools of public health when you combine the two, but it was just not fathomable that this could be done until now. Here I'm triply conflicted because I'm the sponsor when I'm at Verily. I'm vice chancellor at Duke and also have a Stanford appointment just to be balanced. So both academic centers and Duke and Verily are my employers. So the idea here now is to develop a set of tools based on the richness of cloud computing and infinite processing and really smart software engineers who don't want to just write better algorithms for advertising, but are very interested now in human health and do it differently. E-consent is kind of the easy part, but I think it takes a disruptive force to get all of the people that are currently doing things by the current method to change what they're doing. But the simple idea here is we're all using cell phones every day, and giving someone the option to dive deep if they want to know a lot about the topic or to just get the essentials is really an interactive system, much better than the 20-page single-spaced sheets of paper that we've grown used to. Allowing people to interact directly. I am a little distressed because this shows a computer screen, which I like. I love to work on a laptop, but I'm learning that millennials on down, there's almost no laptop use anymore. Everything is done on the cell phone. So I'm a little scared about that. I might not make it when I'm 85. But there is absolutely no limitation other than the physical tolerance of the person participating in the study to do everything that I'm showing on this slide. It's being done in a 2-day visit. And I'll show you more about the depth of the data. But that's on the 2-day visit. Then people go home with a watch that measures 17 parameters, a sleep monitor, and an Android phone that has everything built in it to learn as much as possible about you as possibly can be done. And you probably know there's a lot being learned about you every day for commercial purposes already. The issue here is, can we take this information and turn it into something useful for your health? The mobile apps here are fascinating to learn about. I'm far from an expert, but things are moving along very quickly. And if you read one thing about this, I would urge you to read Tom Insel's article in JAMA just about 3 weeks ago now on digital phenotyping. And Tom left the NIMH and went to work at Verily, got so excited about this, he's now CEO of a tiny startup from a Stanford professor, totally dedicated to learning about mental health using cell phones. And how many of you know what the word prosody means? I had no idea. Prosody refers to the ability to understand things from the tone of your voice and the prose that you use, not the content of what you're saying. So if you want to know if someone has cognitive decline, it's pretty easy to tell from their interaction with a keyboard or a cell phone. If you want to know if they're depressed, the tone of the voice is a good measure. You apply machine learning to it with classification algorithms, and there are other deeper aspects of your interaction with technology that are very revealing about you. These are used every day. How many of you have Alexa? A few. Alexa, as you know, is learning about you every day, and you get different answers to your questions as time goes on, because Alexa's learning from everybody else using Alexa, but also about you as a person, about what you want to hear. So Tom is very focused on the issue of what can you learn about mental health from a smartphone. So all this information together for just the physical visits is 6 terabytes of data per person. You begin to add that up over time continuously. It's a lot of data. And I don't know about RTI, but I just came from a meeting at Duke where we're still worried about computer storage and space for our data. I can say that in my entire time at Google, I have not heard a single sentence about concern about that. So, you know, it's clear where we're headed with this, and we've got to figure out how to turn it into something good and not something bad. And this is just to say that behind all this is a tremendous amount of work in developing the platform. And there's an interesting question at play. If you think about search or maps, you don't pay anything for it, right? If you want to find out where you're going, you might use Apple, you might use Google, but you assume that it's there for free. Question is whether the map to the human being should also be a free item that anyone could use. It would change the playing field for the way human research is done. You can probably tell what I'm lobbying for. So that's one dimension, but what about the way the information is used? And I think it's verifiable, certainly the topic of the day in politics, that we're seeing a huge erosion of public confidence in veracity, the value of credentialed expertise in science itself. And this is not uniform, it's variable depending on where you live and who you associate with. An imposter who knows nothing about the topic can beat you on the internet almost all the time if they know how to get the attention of the audience that's looking at it, even if you spent your whole career becoming an expert in the topic. And certainly little communities in Eastern Europe and the Russians bested all the expertise that Hillary Clinton had in the last election. I think it'll be increasingly obvious, highly effectively. Well, what's a tool that's most often used? Today there will be about 4 billion searches on Google search. One can argue whether it should be that way, but it is. And I'm going to diverge from politics here, which I love to talk about, to something I may know something about, which is health and science. 1 in 20 Google searches are health related. And so there's a mission on the search team, which I've had the privilege of being an advisor to. I'm not in charge of it, and I don't make any of the policies. But I think it's the most underused public health tool in the world today, because almost everybody in every country is using it and is able to use it for free. This is a look at what people search on within health. Most of it is what do I have and what treatment do I need? 16% are home remedies, which is basically how can I avoid going to the doctor? And of course, a lot of the information that's on there is not necessarily the information that most expert professionals would like people to be reading. So the solution to that that's been started, it surprised me. This has been going on for over a year. But when I started at Google and started to ask audiences like yours how many people knew about it, the solution now has been the creation of what's called a knowledge panel. And this is curated information that's based on expert curation by entities like the Mayo Clinic, and represents the state of knowledge taken to a level, remembering this is a tool for the world. So it reminds me of the revelation I had at FDA when I realized that labels on food had to be written for 320 million people at all levels of education. So it's not a simple task to find the sweet spot here. And it can't practice medicine, so it can't tell you to take drug A for condition B. What it's doing is informing people. And the question then is, if they're steered to better information, will it help them make better decisions? An interesting little factoid at Stanford, on average, not only is a patient going home right after going to the doctor and Googling, but the doctor actually has Google open now and not up to date on average in the clinic. And many of you are expert in this, but I'm openly looking for people who can solve one of the biggest problems that exists in the search environment. People are desperate to know about, should I take this drug that my doctor just prescribed? And they want to know about the side effects. But of course, what's in the label is everything that happens to people, whether it was caused by the drug or not. And how to convey the right information to people to help them make good decisions, I think, is a still open area for someone to figure out. If you do, we have a way to get it to half the world's population every day. So we're very open to that. And then how do we help people find action that they can take without having Dr. Google practicing medicine, which is against the law? And the place we chose to start was depression, and I say we liberally again, this is not me. I'm an advisor to much smarter 25-year-olds who are doing most of this. But it's obvious that just like if someone is showing you how to create a bomb for terrorism, that should be taken off the internet. That's now happening. In the same way, if you're searching saying, I want to know how to kill myself, rather than showing you how to kill yourself, I think most of us would be in favor of Dr. Google interceding and giving the person a referral to the hotline for a suicide. And that's happening. Then the next level is, what if I'm searching on depression? And the real motivating factor here is that, as all of you probably know, about 1/10 of the world's population is depressed on any given day. It's true in every society. About half of people never get treatment. And in those who do, the average time to first recognition and treatment is about 7 years. And the treatment is effective. It's not 100% effective. It's like most things in medicine. It's partially effective, but it makes a difference. So we'd like to get people to treatment if they're depressed. And so now what happens if you're searching on depression? This is only about a month old. a question comes up that says, would you like to take a questionnaire? And if you say yes, then you're taking the PHQ-9, which is a validated questionnaire for screening in primary care clinics. And we've got a lot of experience in a month, I can assure you. I'm not at liberty to talk about the details yet, but let's just say there are a lot of depressed people out there who actually are very willing to take a questionnaire. And so you can imagine the knowledge panel might look different if you score, in the worst tertile of depression. So hopefully this has given you a little bit of insight into what's motivating me. Now the question is, what can we do to adapt to this world, which is already upon us? And I would say we have some work to do in our highest levels of profession. One of the real keys here is having good data going into the computer. So we really need to reward people who clean up data, which, as you know, is not something in academic centers that's rewarded. Here at a place like RTI, it is. But we need, and particularly in health and healthcare, much better data. The biggest problem is sharing information. And there's, historical reason that we've gotten in the place that we've gotten. But we're now in a situation where it's abundantly clear that if we want to solve medical problems, we can do it a log order faster if we share data. And the chief proponent actually became Joe Biden. And if you go to one of his talks, I think you'll find it interesting because his new institute is focused on money for cancer research, but an equal emphasis on data sharing, because he observed that with his son's glioblastoma, there was no hope that people could do the clinical trials at one center, but he noticed that within the glioblastoma community, there was not a lot of sharing of data. And I'll finish just quickly pointing this one out, which I still sort of am trying to absorb. But this is sort of a look at least one person's depiction of what search actually is. It's a network of information where the entire network is being watched all the time and constantly learning how to make the information better and more precise. And when there's a question about how to do it better, a pragmatic randomized trial of a large scale is done to get the right answer, and the system changes and moves on in a very adaptive fashion. And it fits in with this view of where computing is going, from optimizing the function of the individual to optimizing group learning, which is a much more efficient and effective way to learn, at least about some things. We'll obviously still need the genius individual that comes up with a great idea, but iterating on issues, particularly in health and healthcare, I think is the right way to do it. So the very last thing is we do have a new center at Duke. You're among the first to see the name, which is a crazy name, but this is on actionable health data. And the Forge really rose to the top after a while because we've got to meld a bunch of rigid structures which are not easily combined into something that creates a synthesis of information which is much better. You can all put yourselves into one category or another of workers in the Forge if you'd like. You can see the job descriptions here. We've got wheelwrights and armorers and welders. But I really think the key to the future is us taking this amazing change in technology, and instead of having it be used for targeted advertisements for financial reasons, have it used to help people change their behavior and their interactions in a way which leads to better health and longer life. So I'll stop there, and hopefully we'll have a few minutes here for questions. Thank you. Yes.
One of your early slides had a citation. One of your early slides had a citation from Haynes, and I know around circulating around here over the weekend was an article that came out in Politico about the
budgeting for the national statistical system and the budgets that are being cut and the ability to really generate the kind of quality data. Obviously, the new technologies will help drive that, but what's your sense inside the federal government, if you can share a perspective of the appetite in the agencies for moving in some of these directions?
Yeah, I mentioned to Wayne, there's not a question you could ask after going through a Senate confirmation that would bother me at all. So I'll just let it fly here. I think the appetite within the federal agencies is tremendous, and people in federal agencies want to practice evidence-based decision making. This has been their careers. The political people currently being appointed, and many politicians are opposed to it. And I'll just mention, you can go look at it. There was a provision in a bill that didn't get very far that 2 senators put forward that would make it illegal to use federal data to create geospatial information about disparities. Now, it's as if you don't measure it, then it doesn't exist. When I think the key is to constantly measure it, do interventions, and turn it around. That's the way businesses work, and I think if we're in the business of helping people improve their health, we should do it. So I think you've got to dissociate, the working class of the federal agencies from the current leadership. And I don't need to tell you about EPA. You can just read about it in the papers.
I have a question about combining a full portfolio of conditions for an individual. What are you seeing, or what are you thinking about, say, combining, say, both comorbidities but also conditions in between? What leverage do you have or imagine having for being able to combine clinical trials to capture, say, an intersection between 2 diseases, or to weight the application of that, quote, intermediate condition to the specific conditions that are on?
So, I'll talk about this at 2 levels. If we just start with the baseline study that I showed you at the fundamental level of the individual human being and their interaction with the environment and other human beings, my prediction based on preliminary evidence, not from our study, but other things that I'm seeing, is that we're going to see systems where there are critical nodes in the systems that relate to multiple things that we would call diseases that are interrelated in various ways. That's a quantitative measurement issue that we just couldn't approach before because it didn't have the computing power to do it. Then you get into the issue of interventions where you have multiple characteristics of a person in terms of their response, and even the possibility that things that are good for one disease are bad for another, which we already know is true. I just think it's a matter of time until we have more and more knowledge about individuals, so we begin to see that. And then, if we just go back to what I love doing, which is the basis for the FDA, estimating the risk and the benefit, the integrated risk and the integrated benefit will be something that looks quite different in the future than it does now. Maybe you're putting off risk of having a stroke, but you're increasing your risk of cancer 10 years later. We couldn't think about that before. I think we'll well be able to in the datafied environment. Yes?
I love the idea of the pragmatic collection of data and the use of it. Speaking of the geospatial differences, though, that red-blue map, that was very enlightening. Looks like it could be pointing towards some difficulties in collecting the kind of individual data that you're talking about in the sensory way that you're talking about it. I'm just wondering how we reach all of those individuals and get all of that data that could show us a lot of the disparity and get back out to the people whose behaviors we want to affect, so that we are more egalitarian in the way that we do this.
I don't have a very coherent answer to that, other than to point out that the collection of most of the data is going to become very, very cheap. The goal at least in the place where I'm working, what you learn right away is that anything you take from even a good example is photographing food. the software for calculating what's in food has gotten really, really good. But if someone has to actually take a photograph, you lose a very high proportion of people right from the get-go. So anything you can make passive and automatic, you really, really increase your generalizability to the big population. Yeah, I'm worried about something I wasn't worried about before. The big worry used to be particularly African American and Hispanic poor people in terms of getting access, and that's still a worry. But the big population that could become so cynical they won't participate are rural white people. And so we need to think about all of that. It looks like so far, if you're seen as an honest broker and you have a bargain, that is, what you're giving them to people is useful for something else, most people we're finding are pretty amenable to having the information collected. And then the last thing I'll mention, I do think in the area of health, a healthcare provider of some kind in the middle of it is really important, because most people don't want to just interact with a distant thing. There is some literature that men will talk to robots more intimately than to therapists, but we could get into that later. Yes.
I have a question about Project Baseline. So I was really intrigued about it, because there is 23andMe, for example, which I think, well, used to be a very useful project until FDA stopped them from providing useful information. About certain risk factors. But I was thinking about this Project Baseline in the same way. If there is a tool or a baseline or a company where I could say, okay, I'm interested in diabetes risks, and I'm wondering, what are my chances of getting diabetes or developing diabetes in the near future? What kind of information should I provide you? And maybe go through whatever, like 2 days testing, I think is a perfect thing. I'll be just ready to, like, if I get a more answer. But this way, like similarly to 23andMe, can provide my data, but then I will get something back. So I will get kind of like a map. Okay, well, this is my next 10, 15 years, and these are the chances of what could happen to me. Again, it's a matter of how to present it, but I would love to have that resource, because when I go to my physician, I had exactly the same experience that you described. I described what my symptoms, and he's going to WebMD and reads, like, enters what I tell him, and it's like, man, I can do it myself, and already done all my homework. I'm just coming to get something new. So that's what I would.
So just to correct a couple of things, I had a meeting with Ann Wojcicki last week, and 23andMe is rolling. Let me tell you, they're doing well. They've just had a huge amount of infusion of capital, and they have FDA-approved tests now. I would argue the main issue there was, if you're going to do a test and sell it to people with advertising, you'd better make sure that you do it accurately. And there is a law that says you should also be able to describe to people what they should do with the information. And I think there are good reasons for that. But I'd also say, for people like you, I don't think we're that far away from a situation where you could do what you described. Right now it's deep research, but it will evolve fairly quickly. But you should also consider that the majority of the population is not like you. And so, the majority of physicians can't translate a natural probability into a natural frequency. And so it's really important when you promote tests to people that you provide the information about how to interpret it, and that you've actually done the hard work, which takes much larger sample sizes than most laboratorians ever thought, to understand the operating characteristics of the tests. This is a huge issue. So I think the FDA, by and large, say we're totally in favor of consumer laboratory testing, as long as it's accurate and the instructions can be understood by the people to whom it's being sold. Yes.
First, a quick anecdote. you started off by talking about your experience in Colombia, and remember watching you play basketball for Flora. I'm not sure if people realize he was a pretty decent shot, especially from the corner. But I have a question for you about your what you're doing now at Verily. You're talking about the amazing amount of data that's being captured by Google searches. In parallel, there are also a lot of companies that are capturing social media conversations in the billions. The question I have is, all of this data that's coming in is unfiltered. So what do you see, and what do you see for the medical community in terms of the role that they are going to play, or do your colleagues at Verily think that they're going to be able to build programmatic, relevance-based algorithms for telling everybody what this all means?
Asking about what people at Verily or Google think is like asking about what people at RTI think, right? There are a lot of opinions, but I'll give you mine. I think for like the gentleman over there, a special category, probably less than 10% of the population that, really scientifically inclined, very outgoing, wants the information, wants to act on it. There will be consumer-based activities that will allow that person to escape the medical system for as long as they possibly can, if that's what they want to do. For most people, I think the real goal should be to assist the interaction of the person with the healthcare system. And it's easy to use. Doctor is an easy word to use. It's really a proxy for a team of people now. Most people, to interpret information, to think about what actions they need to take, they need some help. And so you described it as unfiltered. I mean, what I think is going to happen is a convergence of I'll use the word machine learning, but it could be multiple quantitative techniques to improve the filtering and the algorithms. But I think at the same time, the health professions need to move in the direction of helping people articulate and put those conversations in the right context. The unknown part for me, which is very exciting but a little bit scary, is the concept that the machine will know a lot more about you than you know about yourself. And if you allow it to do it, we're pretty close to that now. And how to handle that, I'm not sure. It just seems to me that ultimately, and certainly in my experience as an intensive care doctor, the most intelligent people in the world and the most outgoing self-sufficient, when they get sick, it's very hard to see things objectively and make good decisions. So I think it's a team of people that need to be brought together using the technology. And I think that's an articulated goal at the highest levels at Google now. Maybe I'll finish with the example. My dad is 95. He just fell. He's in the hospital. And one of the projects we're working on, which a lot of people are, is the intersection of information and the built environment as people age. Number one desire of people losing cognitive function is to stay at home if they possibly can. But, families hundreds of miles away have a pretty hard time keeping up with things. But you can imagine an environment where it's not that you never want to see your parents, but, I've learned they don't want to see me either, that much. They'd like me to visit, but they really cherish their independence. So you can imagine how the information system could not just help the doctor-patient, but could also help the family of people who are caring about the person communicate better and make better decisions. All right, thanks a bunch.
I have a little gift for you. Thank you. And we really appreciate your giving this lecture. There's a reception afterwards, so we invite everybody to enjoy and